So we were talking about, actually I want to this one. We were talking about the inguinal area and the inguinal canal last time. And so we'll start off with, we did some relations of surface structures and palpable structures in both the male and the female for the inguinal canal. So mostly we're going to focus on the superficial ring of the inguinal canal. So for the male, we can trace the spermatic cord up from the scrotum here up to the superficial ring, inguinal ring. And that's a palpable area in the male. That's also a place where you can palpate for it. A hernia. Ouch. For the female, obviously we don't have the spermatic cord, but the superficial inguinal ring is just superior to the pubic pubic tubercle here. So you can see pubic tubercle here, superficial inguinal ring there. So again, just the pubic tubercle is a palpable area. You can then go up from there slightly laterally to find the superficial inguinal ring. Any questions? Okay. So then what goes wrong? What happens when things go wrong with the inguinal canal? Well, the most common things are inguinal hernias. They happen quite often. Some of them have a congenital aspect of them, and something about both types we're going to talk about is that they're more common in males than females. Predominantly that's because the spermatic cord, a larger structure, passes through the inguinal canal, so it makes the inguinal canal a little bit more susceptible to the structure of the hernia. So there are two different basic types we'll talk about. The indirect inguinal hernia is when a loop of the peritoneum, sometimes, but not always, including a loop of the bowel, moves in through the deep inguinal ring into the inguinal canal. So kind of outpouching through here. It can sometimes move all the way down the spermatic cord into the scrotal area, depending on how bad it is. Can't remember what else I was going to say there, but whatever. The direct inguinal hernias here, and the next one, push through the posterior inguinal wall, the canal wall. So would be the posterior wall there. So they push directly through that. Excuse me. Typically medially too. So this is medial. This is lateral here. Typically medially to the inferior epigastric vessels. This area right here is a little bit weaker area of the inguinal canal, the posterior wall of the inguinal canal. And so you get bulging bulging of the abdominal wall here in this area. Excuse me. Okay. Both of them can occur and do occur when we have the weakness with in the posterior wall. Actually, I'm going to jump back here. With this one here, the indirect inguinal hernia, this is often a congenital. They have congenital propensity for it because the processus vaginalis doesn't completely finish fusing into the inguinal canal. So there's some remnants of patent processus vaginalis, they call it, making this area a little bit weaker than normal. Then the hernia occurs through that weakened area when there's an event that dramatically increases intra-abdominal pressure, pushing the peritoneal sac, and sometimes the bowel out through the out through the weakened area. Oh, okay. All right. We take a look at the interior surface of the abdominal wall. So this is like what we do if we inserted a laparoscopic camera into the abdominal cavity, and we're looking at the surface. So this is medial, this is lateral, and we can see here very nicely the deep inguinal ring of the inguinal canal there, with this is again in the male, the ductus deferens coming in, the testicular vessels here. And what I want to point out here is that the placement here, so the inferior epigastric vessels run just medial to the deep inguinal ring, okay? And then on the other side, we have this inguinal triangle. Some people call it the Hasselbeck's triangle. So, well, we can use this to differentiate between a direct and indirect hernia, because on the superficial aspect of them, they are not distinguishable. It's a mass in the inguinal area, but we can't differentiate between whether it's direct or indirect just through palpation. So we have to go in and look at it. And so what the so with an indirect hernia, that would be a protrusion through where? We just talked about it, indirect hernia.
The inguinal ring.
Yeah, so it goes through the deep inguinal ring. So you're going to see the hernia protruding from this area. With the direct inguinal hernia, it's going to be a protrusion in this area in the inguinal triangle. So if we take a look at what it looks like laparoscopically here, we have a direct hernia. See, so that we got gastric vessels here, medial, lateral, inguinal. The inguinal hernia, you can see that outpouching is medial to the epigastric vessel. So this is your major diagnostic tool for differentiating between the two types of hernias. If it was an indirect hernia, you would see it coming in this area. Okay, here are some MRI images. These are weighted with fat, so the fat is showing up. On the left, we have a right indirect inguinal hernia. You can see kind of a distension of the inguinal canal here, coming down through the spermatic cord into the scrotal area. So this is typical of an indirect hernia. On this side, we have a direct inguinal hernia, and these typically look more like an outpouching. So here you can see here this. Here, first let me orient you. So here's the base of the penis here, and the lower aspects of the abdominal cavity, and then into the inguinal area. And then here is this outpouching. Here is the direct inguinal hernia. And you see this one has a loop of bowel infiltrating the hernia, whereas on this side we have a bilateral hernia here. This one does not have the infiltration of the bowel at that point. Okay. Now, when we have infiltration of the bowel, what is the problem there? What is the risk? The hernia becomes what? Necrotic. It can become necrotic. The term is strangulated. Okay. So the hernia can become strangulated, which means the blood supply is cut off to that loop of bowel that's protruding through the abdominal wall. Then the tissue dies and can become, so it becomes ischemic, can die, and become necrotic, cause all kinds of problems with leaky bowel, et cetera, bad things. So that's a strangulated hernia.
So the bowel goes through the hernia and then it gets basically pinched off?
That's correct. Okay. Any questions about the hernia and inguinal canal, anything like that before we move on? Okay. So then, we'll take a step back and just do some orientation. So now we're going to be looking at, structures in the greater part of the abdominal cavity, the viscera. And so we want to get some orientation terms, and this is the area of the notes where I do not have it filled in, because I can tell you all day long which organs are in which quadrant, but until you go through and learn it, it's not going to do you any good. So what I've done is just list out the different quadrants and asked you to fill in those areas. What I will do today is describe the differences or the boundaries of those quadrants. So we have the 4 abdominal quadrants. They are separated vertically by the transumbilical plane. So this horizontal plane here, that is halfway between the approximately halfway between the xiphoid process and the pubic symphysis at the area of the umbilicus, aka the name transumbilicus. Okay, the vertical dividing line is the median plane, right straight down the medial part of the body from the tip of the xiphoid process to the pubic symphysis. And so then we have the upper quadrants, lower quadrants, right, left quadrants. Okay, so know what organs are in each of those. In practice, a lot of times they're talking about regions or quadrants of the body where there's pain, where there's a mass. You need to know what could those structures that are having pain, or what structures that could have that mass, what's underlying that region of the surface anatomy, so that you can make an informed decision about potential diagnoses. Here's just a surface image showing some of those organs in each of the quadrants. Again, showing that the 2 planes intersect at the umbilicus, the belly button. So again, make sure that you can tell where these the structures are in relation to the 4 quadrants. I just want to point out here, McBurney's point is a point between the anterior superior iliac spine and the umbilicus, and that is typically the location of the appendix. So if you have appendicitis, you'll have pain in that area. So the referred pain will be in that general area there.
What was it between?
They take it out.
Pardon?
What was it between?
Oh.
Is it between those 2 points, or is it at?
Yeah, it's a straight line. So if you draw a straight line between those, it's along that plane.
Gotcha.
Yeah.
1/3 of the distance.
Is it 1/3 of the distance? Okay.
Yeah.
Thank you. All right. So then another way of dividing up the abdomen into region is the 9-region method, and this one also is commonly used. I can't even tell you how many times my medical friends be like, "Oh, I have epigastric pain," instead of just saying my stomach hurts. So it's something they use all the time. These are terms that we need to be familiar with. Again, know what structures or what portions of what structures are in each region. This is also laid out for you to be able to fill in that in your notes. So I'll again talk about the intersecting lines that define the edges of those regions. So vertical lines are the mid-clavicular planes. Remember we talked about that in the thoracic region. We also talked about it here in the abdomen. The middle of the clavicle, drop it straight down. It's about halfway between the pubic symphysis and the anterior superior iliac spine as well. So that divides the abdomen vertically. The horizontal lines are the subcostal plane, which runs just below the inferior edge of the rib cage, just below that lowest point of rib 10. And then the intertubercular plane runs between the excuse me. Runs between the lost my brain.
Midclavicular.
Hmm?
Midclavicular.
Well, the intertubercular plane,
Oh.
runs between the,
Iliac crest.
that's the word, thank you, yeah, iliac crests. Wow, that was bad. Ow. Okay, so then, we have 9 regions. In the center, we have the epigastric. Epi means upper, yeah, it's gastric stomach, so that area. Umbilical would be the region that includes the umbilicus. Pubic would be region includes the pubic area. And then here we have hypochondrium is the top here, the right flank and the right groin, and then reflected bones on the left side. This area can also be called the inguinal area, like we've been studying. So you'll hear also inguinal or groin and used interchangeably.
Is this what you want us to learn it as for the test?
As groin or inguinal.
Oh, I mean, because there's also like pubic region could be like hypogastric.
Yeah.
Right, yeah.
Flank could be lumbar region.
Right. So there are others.
Yeah, I'll
for
just-
this class, I just use the ones here.
Okay.
That just simplifies it for everyone.
That's fine.
Good question, though. Okay. Moving onward. So here's just a surface surface image for those 9 regions. And just note that epigastric is typically has referred pain in the foregut. The umbilical region is where you get referred pain from the midgut, and the pubic region is where you get referred pain from the hindgut. So just to note those. Okay. Any questions before we move on? Okay. All right, so then we've talked about this before. I just want to revisit it really quickly because I like the way these diagrams show it. So the difference between peritoneal and retroperitoneal organs. So with the peritoneal organs here, we see the parietal peritoneum coming up, the folds of the mesenteries arising from it, and then the visceral peritoneum wrapping around the organ. So you see it's actually just a continuous set of tissue. Different regions are called different things, but it's all coming from the same basic membranes. Just to note, remember the mesentery is typically 2-layered, and in between those layers often you have vessels, both blood and lymphatic vessels, as well as nerves running in between those 2 layers. Retroperitoneal organs here, again, are covered by the visceral peritoneum on a portion, but on the back portion, or the portion nearest the abdominal wall, they're actually right up against the abdominal wall. They're behind the peritoneum. There are organs that we call partially retroperitoneal, where part of them are retroperitoneal and part are peritoneal. So just be aware that those are out there too, and we'll talk about them as we get to them. Okay. So because we have all of these membranes flopping around in there, we have several different spaces that we need to talk about. And the 2 that we're going to really get into are the greater and lesser sacs. So the greater sac here is all of the kind of dark purplish stuff in the diagram. And that's just basically all the space around the intestines, outside of the visceral peritoneum, but yet inside the parietal peritoneum. So it's all that space inside the peritoneal cavity. We have another sac. It's the lesser sac. It's also called the omental bursa. So it's also the lesser sac. And this is just the area behind the liver and the stomach. It actually is continuous with the greater sac, but since it's mostly kind of separated away, they give it another name. And it's separated predominantly from the greater sac by the lesser omentum, which which we'll talk about a bit more in a minute.
What did that contain? The liver and what?
Sorry?
What was in the lesser sac?
The lesser sac is just the space behind the liver and the stomach. Mhm. Exactly. Also on this slide, I want to point out the greater omentum. We'll be talking about it in a minute, but I like the way it shows it. So the greater omentum is a fold, kind of folds down like an apron in front of the intestines. And so you can see that here, kind of draped down. And that just, it's a good image of it. They don't show it quite so well anywhere else. So I just want to make sure that you're aware of how it looks from a lateral view.
The lesser omentum is just the dividing line between the lesser sac and greater sac.
Correct. It's what partially and mostly separates it from each other. Okay. Good. So then if we take a look at a cross section here, then we can see again the greater sac, which is all of this area here, kind of around all the organs. If it was lower down in the abdomen, we'd see more space there. And then we have the omental bursa, the lesser sac here behind the stomach and the liver. And then here is the omental foramen, and that's that channel that connects the greater sac and the lesser sac. This figure is also a nice cross section just to help you orient up in the upper abdominal area where things are. Okay. Any questions so far?
So what is it that that separates the greater sac and the lesser sac? Did you say the lesser omentum?
Yes, the lesser omentum, and we'll talk more about that in a bit. But here it is, you can see here, separating the two. Lesser omentum. Yep. Good. Okay. So then let's jump over to the greater omentum. So remember we had that big flap coming down the front of the abdominal cavity, so that is here. And it's a big old fold of the peritoneum, and it's infiltrated with lots of fat. That's fat, and a huge number of blood vessels. So it's very vascularized. At the top, it's attached to the greater curvature of the stomach. And it's attached to the transverse colon. Okay. On the lower end, it does not attach to anything. It's just floating about down there. Does anybody know what the purpose of the greater omentum is?
Cushioning.
Partially it's cushioning, yes. But it has an additional function I think is ridiculously cool. So because it is highly vascularized, and I spelled vascularized wrong, here, okay. It can become a major pathway for infiltration of immune cells into an infected area or an injured area of the viscera. So if you have say a portion of the small intestine that gets infected or inflamed or injured somehow, the greater omentum will actually adhere to that area, actually attach itself to that area, and become like a major highway for infiltration of immune cells into the area to take care of the infection. When the infection is over and everything looks good again, it will detach itself and go back to floating about in the greater sac. But when there's an issue, it's going to come in, adhere to the area that has the problem, and just pump immune cells, lymphocytes into that area to take care of the issue. Now, when we do surgery, now I'm sure you all have heard about adhesions following a surgical procedure. So we've damaged the viscera in that way, so we can have adhesions between the greater omentum and those damaged areas. It also can have adhesions between the viscera, so it's not limited to just between the greater omentum and the injured areas, or the areas that we've touched with the surgical instruments or even sterile gloved hands. So we've messed around in there. It's going to adhere to that area and try to take care of the problem. Unfortunately, when you've got post-surgical adhesions, sometimes that is extensive enough it can start causing problems. You have to go back in and loosen those. But when it's just functionally normally, it's typically a small area that it can adhere to it without causing too many additional problems. So I thought that was a very cool function of the greater omentum. Any questions about that? Okay. So then the lesser omentum, that's again a double layered membrane. It attaches to the lesser curvature of the stomach. That's a good way to remember them. Greater omentum attached to the greater curvature of the stomach. Lesser omentum attached to the lesser curvature of the stomach. And unlike the greater omentum, the lesser omentum is attached on the other side to the liver and the gallbladder here. And not only does it separate the omental bursa from the greater sac, it also provides a pathway for some major vessels in the area, including the hepatic artery proper, the portal, portal vein, the bile duct, the gastric vessels, all of those gastric arteries and veins. So they all travel within this omentum. Now, when we remove a gallbladder, so during gallbladder surgery, we have to take care for those vessels, so they're all running in there. We need to make sure that, number one, we don't nick the ones we want to keep in place, especially like the hepatic artery. That one is very easily nicked during removal of the gallbladder. And also be able to properly dissect around those ducts and vessels that we need to ligate in order to remove the gallbladder. So it's an area of very careful dissection during gallbladder removal.
So do the vessels like run through it, or is it just
Yeah,
like
it kind of
along
runs.
it?
It's a
between layers?
multi-layered membrane, so it runs through the middle of the layers, so between the different layers. Yeah, good question. Any other questions? Okay. So then we have some other membranes that are important in mesenteries. Remember, they rise as double layer folds coming up out of the parietal peritoneum. And there are 3 mesenteries. And though they're all called mesenteries together, there's one that's called the mesentery, which, you know, is nice and confusing. So this one here, the mesentery, it kind of runs along the medial part of the posterior abdominal wall down to the lower right part of the posterior abdominal wall. It comes up and surrounds the small intestines, and suspends the small intestines. We also have the transverse mesocolon. This is another of the mesenteries. It runs along the anterior surface of the pancreas. So the pancreas is another one of our retroperitoneal organs. And comes up and surrounds the transverse colon. So that name kind of helps you put them together. So transverse mesocolon suspends the transverse colon. It's got it's fairly short mesentery, so the transverse colon doesn't move around a whole lot, even though it is suspended in the abdominal cavity. In contrast, the mesentery, so the one that's suspending the small intestines, is large, fan-shaped, and they wander all over the place. So allows for movement of the bowel within that area. And then finally, we have the sigmoid mesocolon, which kind of is a sort of S shape here in the lower left part of the posterior abdominal wall that surrounds and suspends the sigmoid colon. And it's a little bit longer, so the sigmoid colon can actually have several different positions within individuals. It doesn't always stick right where we see it in the diagrams, so it can have some variable positions. Okay. Any questions about the mesenteries or all that? Okay. So then let's switch to the GI tract. So we'll do kind of a tour down the GI tract. We'll start off with the abdominal esophagus. So abdominal esophagus becomes such when it emerges from the esophageal hiatus in the diaphragm. So above that, we just refer to it as the esophagus. As soon as it passes through that esophageal hiatus, we refer to it as the abdominal esophagus. And just as a reminder here, as it is emerging from that esophageal hiatus. The abdominal esophagus is very short. This is that little section between the hiatus and where it joins with the stomach here. So you can see just a tiny little curved area. And that's all we're going to say about the esophagus for now. So then, next structure, as we go down to the GI tract, is the stomach. Obviously, we'll just point out a few structures of the stomach that you need to be able to identify. First of all, the cardia. This is the area of the stomach to which the abdominal esophagus connects. So that the area there. At the top of the stomach, we have this dome-like structure, the fundus. And fundus is just a word that describes dome. It refers to a dome. Just a note for quizzes and especially lab quizzes and things like that. There are funduses all over the place. Well, not all over the place. There's multiple structures that have funduses, so you need to make sure that you are specifying which fundus you're talking about. So I ask for the fundus, like on the diagram like this, you need to specify it in the fundus of the stomach, because you can also have the fundus of the uterus. So make sure that I know that you know that there is multiple different structures with the fundus. And if you've got a medical report that just says in the fundus, you can be like, okay, which organ are we talking about? We have to be specific. We have to know what organ we're talking about, okay? Then we go into the major body of the stomach. So this is the major area, the body. And that takes up the bulk of the stomach. And then we pass into an area here, the pyloric antrum. And then that goes into the pyloric canal, which is kind of the distal part of the stomach that's becoming smaller and leading towards the pyloric sphincter at the pyloric orifice. So then we have the opening between the duodenum and the stomach is the pyloric orifice. And that is constricted by the pyloric sphincter. So this is a circular band of muscle. That keeps that orifice closed until it is supposed to let some of the stomach contents of chyme into the duodenum. So it regulates the passage of the stomach contents into the small intestines. Excuse me. Okay, and then also we have the lesser curvature of the stomach, kind of on the right side, and the greater curvature of the stomach on the left and inferior sides of the stomach. Okay, so just know where they are. So here is just an image of a barium contrast dye radiography showing what the stomach would look like in a radiograph. So we've got the esophagus coming down here. These are inverted, so the barium is actually dark instead of light, like we've been seeing some of them. Somehow the stomach is contracted at this point. So remember, the stomach is a muscular organ. It's constantly sending waves of contraction up and down the organ to mix the food and help prepare it for its passage into the small intestine. You can see there's contraction happening right now. So stomachs don't look all pretty and like the figures in an actual image. They have all of these contractions going on. So you can see it's an irregular shape. And we've got a bolus, a little concentration of the barium in the fundus of the stomach right now. So you can see that. You can also see how some of the dye has passed into the duodenum here. Though we haven't talked about the duodenum yet, I'd like to point out here, this image shows the nice C shape of the duodenum here very, very nicely. So just remember that C shape we'll talk about more. And then you also can see here the junction between the duodenum and the stomach here at the pyloric sphincter, so that muscular area there. Okay. Next question is what provides the blood supply to the stomach. So we've got several I want to talk about. First of all, the major trunk that comes off of the abdominal aorta is called the celiac trunk, exactly. Then we have branches off of that. We have the left gastric artery that branches off of that. And that supplies part of the lesser curvature of the stomach, so that aspect of the stomach, and then the region surrounding it. Then one of the other branches off of the celiac trunk is the common hepatic artery, and one of the branches off of that is the right gastric artery, which helps also supply the that area region around the lesser curvature of the stomach. We also have coming off of the gastroduodenal artery, we have a branch, the right gastroomental artery. So that is going to curve around the greater curvature of the stomach and supply that part of the stomach as well as the greater omentum. A branch off the splenic artery provides the left gastroomental artery, again helping provide blood supply to that area around the greater curvature of the stomach. And then finally, the short gastric arteries supply the fundus of the stomach. Okay, and so again, with all cardiovascular structures we talk about, know the pathways from the major vessels out, because this will help you be able to ID what the structures are and also figure out what would happen if you have blockage in the structures. Maybe blockage leading up to some of these arteries we're talking about. Okay, so that is the stomach. Any questions about the stomach? Okay, so then it's marked on to the duodenum or duodenum, depending on which region of the country you're from. I learned duodenum first, so that's what I typically say. Either is correct. So remember I said the duodenum is C-shaped, so you can see here it's kind of lovely and color-coded and C-shaped right there in our diagram. Tucked in, and just want to mention that the C-shape kind of curves around the pancreas, the head and the neck of the pancreas. And why is this good anatomical arrangement?
Pancreas secretes enzymes
Into the duodenum, so might as well keep those ducts short. Exactly. Good. So we have different regions of the duodenum. We have 4 parts. We have the superior part here, and that goes from the pyloric sphincter out to about where the neck of the gallbladder is. So that's that area that kind of just keeps going about the level of L1, so kind of orienting you with the spaces in the vertebral column. Then it takes a downturn and starts plunging inferiorly. That is the descending part of the duodenum. There we go. And that kind of curves down a little bit towards midline till about the L3 vertebral level. Then it turns sideways again and crosses over midline at the L3 level. This is the inferior part of the duodenum. Here. And then finally, it begins moving superiorly again on the left side of the body as the ascending part. And that ascending part then terminates in the jejunum, the next portion of the small intestine, at this area right here, which we call the duodenal jejunal flexure. Okay, so when you look at the cadaver, you're going to see that C-shaped structure of the duodenum, especially on which cadaver is it? 2, I think. It still has the mesenteries in place, so you can follow that C shape as it plunges down in. Now remember, the duodenum is partially, or the small intestine is partially retroperitoneal. So the duodenum is actually a retroperitoneal part of the small intestine. So it's actually back behind those mesenteries. It plunges down in through and then down around and under those mesenteries. Okay. Any questions so far?
No.
Okay. So then, blood supply to the duodenum. We have 2 different areas where we get blood supply from the duodenum. And remember, I was talking about dividing up the different regions of the gut based on which arteries they get blood supply from. So here we go. We can start differentiating between those two. So the stomach and the duodenum are predominantly the part of the foregut, right? So they get some blood supply from the celiac trunk. The latter part of the duodenum starts getting blood supply from the superior mesenteric, and then the ileum and jejunum, the rest of the small intestine, gets blood supply from the superior mesenteric, so that would be mid-gut area. So,
Can you repeat that, please?
yeah, sure. So, foregut receives the blood supply from the celiac trunk, so that would be the stomach. We saw that the stomach receives blood supply from the celiac trunk, and the duodenum, most of the duodenum. Okay. Then the midgut receives supply from the superior mesenteric artery, so that would be the last portions of the duodenum, the ileum, and the jejunum.
Can we start there for a minute?
Yep. Ouch. Get some cough drop. Okay. Any questions?
And then the
Okay.
back gut.
Behind gut would be large intestine, and that's supplied by which artery?
Inferior mesenteric.
Inferior mesenteric. Very good. So again, helping you orient where things are in the big scale, so that when you look at the details, it starts to make sense how it's all put together. Okay, so ready for blood supply to the duodenum. Okay, so we have branches of the gastroduodenal artery, and that's, remember, a sub-branch off of the celiac trunk. So the celiac trunk to the common hepatic artery to the gastroduodenal artery, yes.
Is hepatic artery proper the same as common hepatic?
No,
Or
no, so that's a good question. So the common hepatic artery comes straight off the celiac trunk,
okay.
and then when it splits with the gastroduodenal artery, it becomes the hepatic artery proper, because then it goes
okay.
straight to the
Okay, so the part
liver.
before that is the common.
Correct.
Okay.
Yes, that's a good question. Okay, so the gastroduodenal artery has a couple of branches coming off of it. And they are the supraduodenal artery here, that takes care of the first part of the duodenum, that superior portion of the duodenum. And then we have the longest blood vessel name ever, I'm sure. For this next group, we have the anterior and posterior superior pancreatico-duodenal arteries. Okay, so we've got the anterior superior pancreatico-duodenal artery, and then we have the posterior superior pancreatico-duodenal artery. Okay, so let's pick those names apart. They're superior because they're coming from the top, from the gastroduodenal artery. They're branches off of that. And they supply the pancreas and the duodenum, or duodenum, so pancreatico-duodenal arteries. Okay. Then, from the underside, we have branches of the superior mesenteric artery, which are the posterior and anterior inferior pancreatico-duodenal arteries here. So these are branches off of the superior mesenteric artery. Yep. And this one's okay. That makes sense? Any questions? Want me to repeat it?
Those just branch then, like behind the duodenum?
Yeah, you kind of see it behind the pyloric atrium of the stomach, the pyloric canal of the stomach, kind of branching off of the superior mesenteric back there. Okay. So then, add another layer of fun on top of it. These superior and inferior pancreatico-duodenal arteries, anastomose, here. So they anastomose. To make sure that if one of those larger vessels gets blocked, you still can get arterial supply to the duodenum. And the superior mesenteric artery is actually one that can very commonly be blocked with atherosclerotic disease, so atherosclerosis plaques. So,
Which one did you say?
sorry?
Which one did you just say?
The superior mesenteric artery.
Okay.
So that way, if the superior mesenteric artery gets a big old plaque in it, you can still get blood supply to the duodenum via the gastroduodenal artery and those superior pancreatico-duodenal branches off of that. Okay? Any questions? That make sense? Did I get it across? Okay. All right, so then let's move from the duodenum. Yes, question?
It's
Oh, it's fine.
We don't.
Okay, we'll continue on next time.
it's
See you tomorrow.
Bye.